Welcome to IRG's Health Talk. I'm Tom Hutler along with Shannon O'Kelly, physical therapist and president of IRG Physical and Hand Therapy. And our guest, Dr. Mark Reid, orthopedic surgeon from Orthopedic Specialists of Seattle.
Dr. Reid, welcome. Thanks for joining us.
Happy to be here.
Hey, before we start talking about medicine, you have a very interesting background. Obviously, Tom mentioned you're an orthopedic surgeon. You have a fellowship in foot and ankle. But you also, prior to going into orthopedics, you were an engineer. Tell us about that experience.
That's right. I was a mechanical engineer for about 7 years, and I worked mostly with the Department of Defense as a civilian contractor, worked a lot on military applications, jet engines, missile guidance systems, etc.
And so being a mechanical engineer, probably you're always fascinated with movement and, you know, the way things are placed and three-dimensional type stuff. And as an orthopedic surgeon, that's a big part of your practice. I mean, looking at the anatomy and trying to enhance and replace and bring the anatomy back to where it was prior to injury. Was that experience as an engineer helpful in orthopedics?
It absolutely is. I think especially in the foot and the ankle, where there are so many bones, so many joints, so many mechanisms, you really have to think about it from an engineering perspective. And I think that my background really helps me in the operating room, in taking care of the patients in the clinic, in knowing those kinematics, those relationships.
Okay, I have to ask. So one day you're sitting at your desk as a mechanical engineer and you're designing propulsion rockets to put on satellites, and all of a sudden you have a premonition that I should go to medical school. How's that work?
So I was about 5 years into my mechanical engineering career, and what I found in the particular company I was working with is, as you advance, you get to do less of the detailed design, less of the hands-on work. When I started, I would design a part, I would go out to the machine shop and watch it made, and then I'd put it together with my own hands, and that was very gratifying, very satisfying. And as you move up, you start doing more program management, less hands-on work, and I was missing that part of engineering. At the same time, I was training in some mixed martial arts on the side, and I got very interested in anatomy, biochemistry, nutrition, and that's really what sparked me. And I had a couple of friends that were orthopedic surgeons, and I just really got interested and observed surgeries, followed them around the clinic, and it was my true passion.
Wow, that's amazing. So you basically left this first career, did you have to go back to undergrad school to get all that prerequisite training done? We talk about organic chemistry, anatomy, physiology. You don't get that in engineering school.
No, you don't. And so I had to go back and do about 2 years of work, taking one class a quarter, all of my organic chemistries, all of my biologies, and the whole process from the time I decided to change careers until I started medical school was about 2.5 years.
And medical school was at, if I remember right, University of Alabama?
Yes. So I was living in Birmingham at the time, and so I was able to stay local and do 4 years of medical school in Birmingham.
And then when you got into your orthopedics training, you also did this extra fellowship. We're hearing a lot about fellowships, and you talk about a foot and ankle fellowship. Tell us about that experience.
So most orthopedic residents now are going into fellowships. It's more and more common these days to subspecialize, and we're seeing that in all fields, not only medicine. So I did one of the premier foot and ankle fellowships in the country, and had the opportunity to work with 3 of the leaders in the foot and ankle field, and really got a vast exposure to all the foot and ankle, from trauma to reconstruction to sports, arthroscopy, etc.
Now I'm ready to ask you a question regarding the foot and ankle. Fascinating area to work in, very complicated. Tell us about these tendons that we often don't hear about, but we call the peroneal tendons.
Right. So everybody, I think, knows about the Achilles tendon and has some knowledge of that. But the peroneal tendons are 2 tendons that run around the back outside of the ankle. They're commonly injured in ankle sprains, and occasionally we'll see some other traumatic injuries to the tendons. But by far, ankle sprains cause the most injuries to the peroneal tendons.
And these injuries to these tendons, there's 2 of them we talk about. I mean, could that be anywhere from tendonitis or a rupture or a tear? Tell us about those injuries.
Sure. By far, most of the injuries I treat involving the peroneals involve tendonitis. Occasionally, we will see on MRI that the patient has a small tear within the tendon. And occasionally, much less often than in the Achilles, we'll see an actual rupture of the tendon.
And what are these signs or symptoms that these patients can experience? Obviously, you talked about some kind of traumatic event like an ankle sprain, but are they just overused sometimes? They just kind of come on with no etiology, really?
Right. So in runners, we can often see overuse injuries to the peroneals, and in other patients who are doing a lot of running and impact sports such as soccer and basketball. They often present to me with pain around the back outside of the ankle, weakness with turning out of the foot, and sometimes they lose what we call proprioception, which is your brain's sense of where your foot is in space, which makes you more susceptible to more injuries down the road.
Do they have swelling and tenderness, or sometimes is kind of that very subtle?
It can be subtle. Oftentimes they are very point tender around the back outside of the ankle. I usually can palpate some warmth and some swelling in that area. And oftentimes they will have pain with the maneuver of turning the foot out.
Obviously, it sounds like you do a very extensive history and physical. Any specific diagnostic test that you might order to really rule out whether it's a tendonitis versus a rupture?
Yes. So if we are concerned or confused about the diagnosis at all, we will often obtain an MRI. An MRI is very good at diagnosing whether there are tears within the tendon, whether there is inflammation and fluid around the tendon, or whether the tendon is actually ruptured.
And then once you identify the problem or the diagnosis, what are the treatment options?
Usually when I think about tendons, what we know about tendons is they have a very poor blood supply, unlike the muscle belly. Since they have poor blood supply, they don't have the greatest healing potential. So usually treatment first involves immobilization for 2 to 4 weeks in a boot. And then I have them undergo a period of strengthening with physical therapy. And we see how they respond to that. And most patients do respond to that and get completely better. Those that do not, then we discuss other treatment options, which may include surgery.
And if that tendon is ruptured and ultimately needs surgery, what does that surgical procedure entail?
Surgery is based on the acuity or the chronicity of the injury. If we catch them quickly and the patients have not responded to physical therapy, then oftentimes we can do a direct repair, similar to how we would repair an Achilles. If the injury is more chronic in nature, then oftentimes we have a significant gap between the two tendon ends, and we have a lot of scar tissue that precludes us sewing the tendon back together. In those cases, we have two options. One is to do a tendon transfer, to take a tendon that helps flex the toes and reroute that so that that acts as the new peroneal tendon to balance the foot. The other thing that we will often do now that's becoming more and more common is to use a cadaver hamstring tendon and route that in as your new peroneal tendon. And I'm doing more and more of those these days.
Okay, so you're basically just reconstructing that tendon. I'm curious, this seems like an injury that probably is in a certain age or certain population based on what you're describing. Do you see this peak at a certain age period for men and women?
I see basically two types of patients with peroneal tendon injuries. The most common would probably be the 20 to 40-year-old very active patient who has injured this from doing some sporting activity. We also tend to see it in patients who may be a bit older, less active, and may have some foot deformity such as flat foot or high arches, which can predispose them to peroneal tendon injury.
Okay, so again, great information. If a listener was thinking, well, I have those symptoms or I might have that problem, how would they get hold of you?
They would contact my office at Orthopedic Specialists of Seattle. We have two offices, one in Wallingford and one in Ballard. I see patients at both sites, and they can contact us at 206-633-8100.
If you'd like more information on this topic, as well as how to contact Dr. Mark Reid, go to orthopedicspecialistofseattle.com, irgpt.com, and click on the Health Experts tab, or go to IRG Physical and Hand Therapy's Facebook page.